Good afternoon, everybody. It is a great pleasure. I'd like to introduce our guest speaker, Dr. John Dean from the Royal College of Physicians, who is the Clinical Director for Quality Improvement. And Dr. John Dean has very kindly agreed to give us an overview of the modern ward round. So without any further ado, could I please hand over to and welcome John. Welcome, John.
Thank you very much indeed, and thanks for asking me. So, yes, I'm John Dean, and I'm Clinical Director of Quality Improvement and Patient Safety at the Royal College of Physicians, and I'm a physician in East Lancashire. And I'm presenting this work on behalf of a wide team that has done work over the last couple of years trying to formalise guidance in terms of modern ward rounds. So what I'm going to do is run through a presentation of key elements of the modern ward rounds guidance, which is now published and available to you all. And then at the end of that, we'll enter into a discussion that might draw out some of the points more, perhaps some of the challenges of implementing this. In 2012, the Royal College of Physicians and Royal College of Nursing produced guidance called Ward Rounds in Medicine, Principles for Best Practice. That guidance was well received. It's been very widely referenced, but I think it's fair to say that many of the elements of it have not been implemented because of lots of challenges in the system. So the group that you see written on the right here, a wide group of multi-professional stakeholders representing professional organisations, also representing patients, and the wider NHS came together to review modern practice around ward rounds. As part of the evidence gathering, we developed quite a wide network of hospitals and practice teams who were doing exemplary work in ward rounds, and we used that evidence to bring together the guidance, which is an amalgamation of good practice. We also used surveys of professional members to understand what was happening, what challenges they were currently finding in terms of delivering effective multidisciplinary working, which should be focused on ward rounds. So in the centre of your screen, you will see what we describe as the effective ward round. What's important in this is the ward round doesn't stand on its own. But we are suggesting that the day will start with a good shift handover. That might be one profession, perhaps nursing. It may be multi-professional. But the information from that shift handover need to then feed into a board round where the multi-professional team come together and understand what's happening with patients on that ward that need review. Following that, there will be a whole series of information that comes together to inform decision making, and the function of the ward round is to collate information and then develop decision making with patients for further action and management. So a key element of this model is the information gathering that feeds into ward rounds. And you'll see a whole series of those, and we'll come on to it in more detail. The ward round itself is a multi-professional approach, so key members of the multi-professional team need to understand how they work together during this. It needs to be understood who's leading it. It should start with a briefing in terms of the purpose, how the team's going to work, what the different roles are. So the key team members need to agree their roles and responsibilities. It's likely, and it should happen, that patients have been prioritised at the board round so that then patients are seen in priority order. And the purpose of the decision making is to confirm the diagnosis, address the patient's questions, review their progress against the plan, check safety measures, teach and learn as a multi-professional team, revise that plan with the patient, and complete structured documentation and assign actions. So that's what happens in the ward round process. It should be followed by a debrief of the team around what's worked well, what hasn't worked well, any challenges that there might be, and any learning that's been. Very importantly, following that, the whole multi-professional team should come back together for an MDT handover around plans for each patient, which may be informed by other things that have happened during that time. And then there are outputs, as you can see from the ward round as well. So that's the idealised process. So I'm just going to, bear with me, try and move down a slide. Okay, so apart from that flow of process and decision making, there are other things that happen in multidisciplinary wards that will inform decision making. And what's key is that multi-professional decision making on the ward round or by the team coming together at another time is central, so that you can see a number of functions that happen on wards by different members or collectively of the multidisciplinary team. And all of that information should feed into and out of the ward round. So we see the ward round as being central to coordination and decision making of the multi-professional team. So we described some fundamentals of ward rounds, that they're well led, that they're structured, that you've got effective teams working together, that there is patient involvement, and that there is education, learning and improvement happening as a core part of them. Two key recommendations you'll see in the middle of this screen. The first is that there is not a need for the continual presence of every member of the multidisciplinary team on the whole ward round, but you must agree how the information from those professionals feeds in and out of the process for good multi-professional decision making. However, the people who know the patient best need to feed into that for their patients, and that is commonly, and probably most commonly, the nurse who's directly looking after the patient. It's also important to try and keep the membership of that multidisciplinary team as consistent as possible, and that requires some planning, because if we have a more constant team, we're more likely to make good decision making and have good communication. So what's happening in practice? Well, the surveys told us quite different things, really. So consultant physicians were saying that somewhere between 10 and 20% of the time, the nurse looking after the patient was input into the decision making on the ward round. Nurses were telling us that they participated in ward round 60% of the time. So there's a difference in concept there around what we mean by involvement in decision making, and that needs to be explored by individual teams. Nurses also stated that they wanted to be much more part of the decision making, but were often prevented to do so by other priorities. Similarly, you'll see the data around pharmacists, a dissonance there between perception of the physicians and perception of the pharmacists in terms of input. But it's clear that medicines management is a key component of multi-professional decision making, so that interaction needs to be agreed. So agreeing the roles of the multi-professional team members and their input to the ward rounds is a vital part of planning. Scheduling is also vital to effective multidisciplinary team working. And what we commonly find when ward rounds and the associated processes are not working well is because there's been a lack of scheduling. The multi-professional team don't all know at what time which things happen. They might start their shifts at a different time for different members of the team. They don't know what time the post-ward round MDT is going to happen. The timing of the ward round might not be the best time to aid patient flow from decision making, or it might take too long. Because we might be trying to do too much during that process. There are things that can improve the speed of ward rounds, and there's good examples of dialogue scripts that can be used that speed up information exchange and decision making. And interruptions are very common, so we need mechanisms to prevent interruptions. Common practice is that coordinators of wards join ward rounds. Coordinators of wards will be interrupted on the ward round, and therefore our recommendation is that they interact with the ward round but are not necessarily present on the whole of the ward round. but that the nurse looking after the patient is the best patient who knows the patient well to impact to the clinical decision making. It's important that other patients and the responsibility of that team are understood by that multi-professional team. So any patients in other areas that require input from that team should be considered during the whole ward round process. So breaking it down, let's think about the time, the preparation before the ward round. Our surveys and experience tell us that when ward rounds aren't functioning well, it's because the preparation has been inadequate. There is dissonant guidance in terms of this. What's important is that good decision making is made by the multi-professional team so that the outcomes and the actions can happen in a timely manner, either directly after that patient or following the ward round. But if there's inadequate preparation, then the decision can't be made and is likely to be delayed till either later in the day or even the next day. And therefore, if that means that the preparation takes time before the ward round starts, we are still more likely to get more timely decisions by that information being available. So the handover of information from the night shift, what the patient's symptoms are, what the patient's questions are, what individual professional reviews have told us, how the information from investigations comes together, needs to be prepared before the ward round, not during the ward round. Otherwise it delays it, there's missing information and decisions don't get taken. So you'll see on the right here some key elements around before the ward round, again highlighting the need for the team to come together and to understand their roles and to plan. So the bottom one is important. So if there are patients with communication difficulties, plan how you're going to deal with those and manage that before you get to the patient, before the ward round. So to some people who've not been involved with ward rounds, they're a little bit of a black box. People huddle together, have conversations, look at screens of computers and sometimes come out with decisions. But actually there's a whole series of decision making that happens and that should happen. What's really important is that is that the patient is involved. They're introduced to people in the ward round, their questions are answered and prepared. And then there's a whole series of information and safety checks that inform decision making. Now, all of those don't happen on the ward round, but if you've got the right preparation, then any that need highlighting because there are abnormalities or concerns would be fed into decision making. And documentation is a key part of ward rounds. Clear, structured documentation with prompts for key areas and actions, clear documentation of decision making, checklists for safety issues, and documenting criteria around discharge, transfer, other decisions, documenting that really clearly. And sharing what is documented in summary form with the patient and family, if that's possible. And there are examples of good practice for that. So a key theme of the Modern Ward Rounds report is that patient involvement, patient-centred. And this is what patients told us in the workshops that we had, that they see the ward round as fundamental to decision making around their care. They need to input to that care and they need to understand the decisions and agree the decisions that come out of it. And if they see effective teams, that gives them confidence in the care. But that's not the end of it. They need to know what's going on. They need an update on how the plan's going later on in the day. So there are some key elements of communication with patients, that they know what's going to happen and when it's going to happen in terms of decision making, that they can input to that with preparation, that there's written information that explains it to them and their families. And as I say, any communication difficulties are preempted and overcome. One of the most fundamental things that patients told us was that they want the professional who's talking to them to be sitting at the same level as they are, not standing over them, not shouting from the end of the bed behind a mask, but sitting down, having a conversation. It's a very simple intervention that makes a huge difference to patients. So address the patient's concerns, ensure there's communication with relatives, and follow up with what's happening. So following the ward round, there should be a debrief. What have we learned? What's gone well? What will we do better next time? And the board round of the whole multidisciplinary team around the actions and decisions to progress that patient's care. Central documentation using whiteboards is helpful so that everybody knows the progress. And if the board round's happened in the morning, then an afternoon huddle to catch up on progress is important. It's also doubly important that if there's not full 7-day working, that on a Friday, the weekend plan is really clear around priorities of who needs what and who needs to be focused on in the weekend ward round. So all of that is great from a human point of view, but if the physical and technical environment isn't right, it's not going to happen well. So we need to make sure that when these discussions and decisions are happening, it's an undisturbed area, that there aren't other tasks happening at the same time, that there isn't cleaning of the floor, that there aren't other conversations going on. It needs to be a quiet environment for clear thinking and decision making. Equipment needs to be maintained and available, but there also need to be opportunities to go into other areas for more confidential conversations or sensitive phone calls or documentation that need to happen. One of the biggest changes in the last 8 years is the role of technology. Computers are now commonplace on ward rounds, and sometimes 3 computers on a ward round. And one of the dangers is the focus becomes the computer and not the patient. But what is equally frustrating is when that computer hasn't been charged or hasn't been kept up to date, or the software isn't working, or the people using it aren't aware of the software, or the Wi-Fi is not working for mobile devices that contact other information. So maintenance and update related to technology is a key part of preparation for ward rounds and part of ongoing housekeeping. Education and learning is fundamental to multi-professional ward rounds and multi-professional care on wards, and it should be seen as a core part of the process. But also training in performing ward round practice, how you share information, how you structure that, how you document it, how do you communicate it and involve patients. And there are examples of good practice where simulated ward rounds develop professional practice. Summarise learning points at the end of the ward round, and patients need to know that education and training is part of that process. So what we include in the modern ward rounds guidance is a self-assessment template for clinical teams on wards for each of the key elements. Where are they on a scale of 1 to 4, and that helps them to highlight the areas where they need improvement or where they can share good practice. And we also have a good practice guidance around examples where all of the elements that I've talked about are happening in the NHS today, but they're not happening consistently and they're not happening necessarily collectively. So Unit 1 have done work internationally around handovers and multi-professional care, and have structured dialogue scripts that can get the interaction with each patient down to between 8 and 13 minutes. I'd really recommend you look at their work. Nottingham University do training of multi-professional staff in various ways for ward rounds and decision making. In my own trust, we've had a model ward round programme where we've tried to develop standard practice across wards, and we're particularly focused on the role of the pharmacist, so that each ward has a dedicated pharmacist taking extended roles on that ward and really contributing to decision making and actions that come out of that. South Tyneside and Sunderland have a well-formatted debrief programme that happens across multiple wards around how things are going, how well people are, how well the team is functioning. In Sweden, modernwardrounds.net actually do 80% of their ward round not at the bedside, but with a patient in another private room. And this is on a general medical ward, which includes elderly patients. Again, look at their work. It is quite illuminating. In Southend, they've really advanced criteria-led discharge and the documentation of that. In Surrey and Sussex, they've trained literally thousands of practitioners in ward round practice. And in Warrington, Holton and teaching hospitals, ward round practice is a core part of their ward accreditation scheme. And I think we're increasingly seeing that across multi-professional ward accreditation schemes. So hopefully what I've been able to share with you today is a summary of the report, some key stimuluses for you to look within your areas around self-assessing against practice, look in the guidance at good practice, look in more detail at some of the recommendations, but importantly, share that practice through your network so we can learn together how to develop this practice further. Thank you very much. Excellent presentation, and thank you so much for spending the time to share the modern ward round with us. And it really is it's of such value that we are keeping our patients at the centre of our decision-making process, and they're part of that decision-making process, which is really central for everything we do. Paul, you've got your hand up. Is it a question you'd like to ask?
Oh, thank you, Jane. Yes, thanks, John. This is absolutely fantastic presentation, and it's something I think, with your permission, we'll share the recording with our team nationally around that, because we're heavily involved, as you know, from the Emergency Care Improvement Support Team point of view with some of what you're doing there. And I think particularly your checklist, your kind of self-assessment of how you are against the best practice. I think that's fantastic, and I'm sure my colleagues Nick and Jen would agree. But just a personal question for myself, John, just a bit of an operational one, really. I think often when we've been helping teams to improve patient flow as a result of getting good ward rounds in place, it's the work that generates from the ward rounds that can be sometimes quite tricky to get done in a timely way, and particularly things like the patient's medications, the TTOs being written up quickly, and having the capacity really in the more junior medical team to, having identified patients who can go home. I mean, in your scenario here, you'd be proactively identifying those patients the day before, potentially, I would have thought, rather than on the day. But then having the means to get the right staff to be able to write up those TTOs in a timely way. And often we see, as I'm sure you do when you go around the country and you help teams with this, colleagues will come back to the patient at the very end of the day, or even the next day, to do the discharge work that could have been done hours before, and that's just because of competing priorities. Yeah. Would you have any kind of guidance or kind of
a few thoughts and guidance on that from my own practice and from what other people have shared. I think fundamental to this is being really clear in the multi-professional team that's on the ward that day who's doing what, and many members of the multi-professional team can take actions related to, for example, discharge communication. We've certainly found in our own work that the role of the ward-based pharmacist and actually pharmacy technician is fundamental in that. So in our own practice, in terms of the medicines to go home, they do 90% of the preparation of that and documentation of that, and then the prescriber checks it and signs it off, and that's become embedded in our practice locally. But what's fundamental is that board round at the start of the day, and that the whole multi-professional team are involved in that you're highlighting this patient, we decided could go home today. Is there anything blocking that? There's been a delay in writing the discharge because of this, that and the other. Who's going to do it? And you decide then and there who's going to do it and whether they need another review or not. Because if they don't and nothing's changed, then you have actions coming out of that for whichever team member is appropriate. The second one is that don't see the ward round as a batch. So things happen in parallel with the ward round. If you're fortunate enough to have a team who can not all be there for every patient, then actually, and certainly my practice is when we've got adequate staff on the ward, they may be junior doctors, they They may be physician associates, they may be advanced nurse practitioners. When you've seen one patient, there are actions that can be taken that need to take place then and there. Then they peel off and they happen then and there, and then they join. So again, that's about structuring it. It's about planning it. And you can do that with alternate patients or taking priority for a bay of patients or whatever, but it's about how you structure your team and your team roles for that constant flow of actions. And really then, the post-ward round, it should be a wrap-up, frankly. Most of that communication should have happened, but it's a wrap-up and a checkpoint, and just to make sure everything's in place. So, and when that works well, it's really rewarding professional practice. And when it doesn't, it's frustrating.
Oh, John, that's really helpful. Thank you.
Nick, you got a question?
Yeah, thanks, Jen and Johnny. Again, another great, presentation was great. Thank you very much for that. I think such an important area, ward rounds, and it shouldn't be time consuming. It should be an important part of the role. But for ward doctors, it is such a fundamental part of what they do. And a big part of the day, isn't it? The ward round. And for me, I think it's at times it's not given the attention it's due for such an important piece of work. And I think you've stressed there about from the patients and the family's perspective. I'm not always sure that that's always at the centre of ward rounds, and potentially sometimes it's perceived as a information gathering exercise for us as healthcare staff, rather than for the patient to be informed or the family to be informed. But I know as a family member who've had relatives on the ward, you're waiting for the ward round to happen, aren't you?
Exactly.
To get that information. So I think it's really important. So I think there's lots and lots of really sensible, pragmatic suggestions you pull together there that could easily apply. So the question really is, what do you see as either the perceived or actual barriers that's getting in the way of this kind of work moving forward?
I think it starts with a perceptual thing that, in some people, one of the barriers is that some staff see the ward round as a doctor thing rather than a multi-professional team thing. Yeah. So that's the starting point. This is about care planning and monitoring of the patient and decision making by the multi-professional team. And the doctor might be leading that, though we've got examples of good practice where it's other healthcare professionals that are leading that. So it has to be seen as a multi-professional thing, and obviously the patient involved in that. That's the first barrier. The second barrier is scheduling. So 2 ward rounds happening at the same time with patients in the same bay, and then, well, why aren't the multi-professional team all involved with those patients? Well, it's physically impossible, yeah. Or the nurses handing out medicines at the same time that the ward round is happening. It's physically impossible for people to be contributing. Or the shifts start at a different time of the day. Or the person leading the ward round doesn't turn up at the same time every day, so that other members of the staff don't know what time it's going to happen. There are other barriers that come in that are probably not, not solvable. So patients do require investigations, do require going off the wards at that time. However, there's some really interesting work that was done in Birmingham that you're probably aware of, which is the My Day work, where patients actually have a diary of what's happening during the day. So if you know that, then you can schedule the multi-professional decision making around that patient's diary. So they may not be at the bed at the time when you're at that bed, but the chances are they will be at a certain time, and you know when that is. But I think there's that cultural bit about it being multi-professional. I think scheduling is the biggest barrier, and then role allocation, and there's that team working on the ward, that debrief, what's your role, who's doing what, that consistency. I think for people who aren't working in the same multidisciplinary ward every day, one of the barriers is different practice in different wards in the same organisation. And for people that move between organisations, that's even more challenging. So I do think there needs to be standardisation of core elements across an organisation, certainly across specialties, but then adaptation dependent on local context as well. But the huge variation is certainly a barrier as well.
Thanks for that, John. Great advice. Cheers.
Just a quick question from me, John, and I'm just reflecting on as we've gone through the COVID pandemic and how we've embraced the technology, and this is an example of how we've embraced the technology to, you know, with the introduction of video conferencing, etc., etc. How do you see the future of a modern ward round being potentially developed to be encapsulating video conferencing, you know, etc., etc.?
Yeah, it's happening. It's happening now. So we've seen it in terms of involving family members in discussions and decision making on ward rounds, or following that in a patient-centred discussion. We've seen it in terms of involving extended members of the healthcare team in that decision making through video conferencing. In my own trust, the post ward round MDTs all happened on Teams. Yeah. So it's known. So one of the wards I work on, it happens at 11:45 every day. Another one I work on, it happens at 1 o'clock every day. So that the extended members of the care team are all on that. People aren't all crouched in an office together because of social distancing, and that was the driver. But actually, what's happened is that extended members of the team are part of that post-ward round MDT. It's team-based, it's coached by the ward and led by the ward coordinator. So we can bring people together much more effectively who may be at a distance or may be covering a number of wards, for example. So that's a couple of examples that I think are happening now. There are examples from particularly rehabilitation sites where specialists may be connected into individual decision making through video conferencing, and even to the extent where the person on that ward might be examining the patient and the specialist is observing that, or then contributing to the conversation with the patient or the decision making, and that gets much better extended team access to patients who may be in a slightly different setting, perhaps a less accessible setting for people that have got multiple obligations.
Super. The art of the possible is really out there, isn't
Absolutely.
it? Really, and perhaps the COVID experience has given us the caveat to take things forward that we probably wouldn't have.
I think it's broken our mental boundaries, hasn't it? It's taken down some of our mental boundaries.
Absolutely. Nick?
Just one last one for me, John, just as you were talking now, I'm thinking, a lot of the work that we're involved in is helping people just get started with something, and often these are big pieces of work, and you often worry about or wonder where do we even begin with this. This is the big piece of work. What would be some top tips for an organisation now that was just looking to get started with something like this?
I think the fundamental part is multi-professional working. So I would start with scheduling, with shift start times. So does everybody come onto the ward at the same time? At least, most of the multi-professional, or there is a time when everybody's together, and then you start that day with the team coming together and doing a huddle or a board round. That's the first thing, because A, it brings that team together at the start of the day, who's in the team, etc. B, it starts to create that sense of team. So that would be the first thing. The advice we had from Unit 1, who've done this work internationally, and I don't think, well, certainly we're not doing this yet, although it's the next stage we're going to move on to, is that they said that the really good, speedy decision making, what was fundamental to that was the structured information from the nursing handover in the morning at the start of the shift, from how that patient had been overnight, what their observations were, whether they'd had their breakfast, had they been able to do this or that for the mother, did they have any concerns, that in a structured way that was fed into the multi-professional process. There are great examples, some great examples of that in the UK. But I think that is a key area to start, because if you've got good information coming in, then you can make good decisions. You're not chasing around about that. And how many of us has been in situations where decisions have been made, and then the nurse or the patient will say, "Oh, well, yeah, that can't happen because." Well, if you'd known the because, before in that conversation, then you would have collectively made a different decision.
Thanks.
So those would be my early pieces of advice.
Thanks, John. Paul?
Thanks, Jen. John, just one last one from me as well, if I may, and it's around the timeliness of board rounds and consistency. You touched on consistency, and we see and understand that the key thing for that, and often where we see physicians of the week in place that kind of don't have to relearn a ward full of patients every day and things. But I was just thinking about the timeliness of board rounds, and would you have a view on what's the ultimate time to undertake the board round? Not necessarily from a patient flow point of view, but it might be in terms of the medical. So if you're a consultant or registrar and thinking about medical job planning and trying to convince people that actually it's all of our interest to get great patient flow, but how do you then convince a clinician that might be coming to work and actually have 2 or 3 jobs to do at the same time?
I think what's important with that is the pre and post ward round. Yeah, I think where people have become confused is because there are different practices around that. You need both. You need the start of the shift, what's going on, what do we need to prioritise, who needs to do what. And I think that needs to be as early as possible in the day when people's shifts are happening, the medical leader is available, other members of the team are there. So as early as possible. There can then, and probably should then, be a pause until the ward round starts where all the information is being gathered. And again, that's not common practice unless you're able to structure your team in a way to do that by doing it a small number of patients at a time. And then, as I say, the post board round is absolutely vital as well. And again, it doesn't necessarily matter what time that is. What matters is it's a consistent time, because then you can change your job plans around that. You can make sure everybody's involved. As I say, if staff are working across more than one ward, then make sure it's not happening at the same time on those wards. But you can do that as we do through teams. So that will be my thinking.
That's brilliant. Thank you, John.
So just to sum up, John, thank you for your time today. It's been absolutely invaluable, and it's been super interesting to hear the concept and how the concept's moved on, and how we can be taking the modern ward round to the next level with the, keeping the patients at the centre of everything we do, but really adopting the technology that we've got at our disposal. And that multidisciplinary teamwork and an acknowledgement of the scope of the roles is absolutely vital in taking everything forward in this direction. So from myself and Paul, from an improvement collaborative perspective, I'd like to say thank you so much. And I'd like to thank you on behalf of the wider membership of the collaborative who will be watching this retrospectively. So thank you, John, and have a safe afternoon.
Thank you very much indeed.